Thank you everyone for coming tonight. Tonight we have with us Dr. Francesco Mangano, who is a neurosurgeon out at Cincinnati Children's Hospital. And we're really excited to have him with us. I don't know that we've ever had a doctor of osteopathy on before, and I'm actually really just personally nerded out to be talking to an osteopathic doctor. But first I kind of just wanted you to introduce yourself, why you're interested in Chiari, how you kind of got involved, and I guess just to start there.
Sure. Yeah, so I'm a pediatric neurosurgeon at Cincinnati Children's Hospital and a professor of neurosurgery and pediatrics at the University of Cincinnati, the College of Medicine Department of Neurosurgery here. I've been a pediatric neurosurgeon since 2005 when I finished my training. And really, as a pediatric neurosurgeon, which is my chosen career because I get to treat all kinds of different conditions, and Chiari-1 malformation being one of them. We see a lot of referrals with this particular condition from children that come to see us, and it's a fascinating diagnosis. There's so much that is now known about it, and so much that is still unknown about it, that it really has piqued my interest, and I've been able to participate with other clinicians from around the US and around the world in studying this problem, and it's very satisfying to actually get good outcomes with the children that we treat, and getting them to feel better from medical or surgical management that we recommend.
That's great, thank you. So I'm going to dive in. I know we have people who are very far away, so I'm going to try and prioritize some of their questions. I think I will start with, I'll start here because this is actually a really good one to bring up. Someone would have had an MRI maybe 9-10 years ago, and the condition had been missed, Chiari specifically, I imagine. In your opinion, had it been diagnosed those many years ago, would that have made a difference in the symptoms progression or how they're feeling today?
Sure. Well, generally speaking, the way that a patient will present with their initial diagnosis will be the way that the symptoms will progress. Meaning, if the majority of Chiari-1 malformations are actually incidental findings and really diagnosed in patients that are asymptomatic, it's unlikely that with follow-up imaging and follow-up clinical exams that is going to change. It can happen, but it's unlikely. Therefore, someone being diagnosed 10 years ago with symptoms, those symptoms would probably have remained the same. And if they were certainly consistent with the Chiari-1 malformation, I believe that the clinician at that point in time would have made the connection between the anatomic abnormality and the symptoms that were presented at the time.
Yeah. To that point a little bit, I think most of the people on this call and who are watching at home afterwards know that the condition is diagnosed by MRI. So understanding that the symptoms are more important, is it possible that the condition can be worse symptomatically than what the MRI seems to show? Because a lot of surgeons will say, well, this is a mild Chiari, you don't need a surgery. And how do you determine what is a mild Chiari, I guess?
Right, it's very ambiguous, right? So we generally look at the scans, and we look at things like, do the tonsils appear pointed? Does there seem to be CSF around the periphery of the tonsil, usually in the sagittal and axial plane? Is there any space between the anterior portion of the tonsil and the posterior aspect of the brainstem? These are the kinds of imaging qualities that we would evaluate and tell someone whether we think something is mild, moderate, or severe. It also depends on the amount of tonsillar descent that we see. That also tends to put more of a crowding in the craniocervical junction and perhaps cause somebody to call an abnormality mild, moderate, or severe. So Take me back to your question, I'm sorry.
So I guess the question is, can the MRI look not so terrible, but the symptoms be pretty awful?
Absolutely. So I think that both ends of or both sides of the coin can occur. You can have a patient that presents with what might be considered, 5 millimeter tonsillar ectopia that looks relatively mild and have very significant symptoms with the Chiari. I've also seen pediatric patients present to us with 10 and 15 millimeter Chiaris and absolutely no symptoms whatsoever. And again, an incidental finding because the imaging was ordered for some other reason. And there they are in your office talking to you about a new diagnosis. So I think both of those scenarios can happen and do happen relatively frequently, actually.
Yeah. So I want to ask one question before I address a question that came up in the chat, because I think it's going to help inform that. It'll make sense in a minute. So what are the symptoms of craniocervical instability and like atlantoaxial instability? How common is something like that, and what are the treatments for it?
Sure. So the symptoms of atlantoaxial instability can really be very mild or can be quite severe. Generally speaking, what you have is a changing in size of the craniocervical canal in the upper cervical spine that occurs with dynamic motion of the head and neck. This can be identified with imaging that demonstrates a significant amount of atlantodental measurement, usually greater than 5 millimeters, the ADI as it's called. Now, the symptoms that go along with that can be anything if I can call it as mild as neck pain or as significant as a myelopathy. There can be significant compression of the brainstem that can cause weakness, sensory changes, really from the level of the compression down. So you could see that in the arms, in the hands, in the legs, even with bowel and bladder symptoms. And if it were to be really significant, you might even see changes in respiratory effort that can affect the diaphragm. So really, it can be a very significant problem, and it needs to be further evaluated if there's a concern that a patient is presenting with instability.
How would someone be worked up for something like that?
Sure. Well, an MRI is certainly a good place to start, to take a look at the craniocervical junction, evaluate all of the anatomic structures that are in that region, including whether there's a presence of a Chiari malformation or not, even a Syrinx. Dynamic imaging can also help. The dynamic imaging that I referred to before is basically flexion extension X-rays of the cervical spine that can be done very easily and measured on the X-ray itself. There are also other kinds of measurements that are a little bit more complex than that, that have been described specifically in the pediatric population, but can be measured in anyone really. One would be an evaluation of the odontoid and checking to see if the odontoid is retroflexed. There's a measurement called the Cc2 line that essentially creates a perpendicular measurement that extends from a line that is drawn from the clivus to the back of the body of C2, and then from that line you measure the distance that the odontoid is extending into the cervical canal. That can certainly be a problem. What's really interesting that actually just showed up on my desk today because I just received a new Journal of Neurosurgery Pediatrics is a very novel measurement that I actually brought.
This is exciting. It's like breaking news.
It actually is. And it's called the Cc2 Sba Measurement. And it essentially is a measurement of, and I'm looking down because I'm just reading about it today, but is a measurement that is essentially looking at the balance of the head on the cervical spine. And it's really more about balance than it is about instability. However, this measurement, which is, I'm just going to read it for you, is the position of the midpoint of the Atlanto-occipital joint on the C2-3 disc space. And it is measured in millimeters. When that measurement is greater than 5 millimeters, it is very specific and sensitive for patients that would end up requiring either a posterior fusion or a ventral decompression related to their anomalies. Like I said, it's hot off the press. I just read some of the article today, and I do believe that this might be a new and better way to think about craniocervical instability, or at least craniocervical alignment, the way that we think about sagittal alignment, or patients that have different types of malalignments in their spine, whether it's thoracic or even sagittal in the whole spinal axis. So more to come on that, but that is right off the press.
Wow, that's really cool. And so you say it's specific and sensitive. So just to, I think I know what you mean by that. So that means that it, with a high probability, that patient would probably need a surgery. So
that's right.
Break it down.
That's right. And the article that I read actually states that it is more specific and more sensitive than those two measurements that I mentioned before, the PBC2 line, as well as we didn't talk about it, but the Climal axial angle is another very common measurement that we generally use to also define different problems at the craniocervical junction.
What was it called again? Just, I'm curious.
The new measurement? The new measurement is the Cc2 Sba measurement.
Okay.
Yes.
They're gonna have to come up with a kitschier word.
It's a little bit, yeah. If I can, let me see if I can. Well, if you give me a minute, I can listen to you, but if you give me a minute, I'll try to find.
I can try and find the abstract even while you're answering the next one. But the reason I wanted to talk about CCI and AAI is really because there are some genetic components to craniocervical instability, connective tissue disorders, and Chiari as well. But I guess the question really is this something that should be tested for down generations? So is this something that someone should get their son to have an MRI for Chiari, or have some sort of a genetic or even hypermobility testing, keep an eye on those things? Is that recommended?
As far as I know, not necessarily prophylactically recommended, meaning that everyone should just be tested for it. My experience has been with the complex type of Chiari malformations, which is really what we're talking about. The patient who presents with what you might consider a simple Chiari malformation that is non-syndromic and just related to the tonsillar herniation causing symptoms, that patient typically does not have any of the conditions that you just mentioned. The more complex patients may, and at this point in time, we really are looking at a low percentage of individuals that have a genetic component to their Chiari malformation, maybe around 3%. And so it wouldn't really make sense to be testing everybody in the family for some type of a genetic component that could also include the Chiari-1. However, if you have a Chiari-1 malformation and it appears to be a complex type of malformation, and then there are symptoms that may be related to insufficiency or instability, if you will, then I think it will be worthwhile to do further studies, as we discussed, to try to make that diagnosis.
Yeah, that's good to know. One thing, I kind of touched on this, but I want to come back to it. Is surgery always necessary? So like you were saying, there are a lot of people who have Chiari, some of it's not genetic, and some of it is not even symptomatic. So say someone comes in with a big Chiari but no symptoms, is that someone that should have a decompression? And I have a follow-up sort of question to this.
The way that I think about the Chiari malformation is that, as you mentioned earlier in our conversation, this is a radiographic diagnosis. And so in order for me to think about a decompression or a surgery that's going to be associated with that radiographic diagnosis, you need some sort of clinical correlation or symptoms. And the analogy that I use is that if you have a Chiari 1 malformation and you're completely asymptomatic, you're going to be exactly the same, assuming you have no complications, once you have a decompression. And so if you're starting out with no symptoms, a surgeon is not really going to make you any better than having no symptoms. And so to answer your question, the way that I think about the Chiari 1 malformation is you have a radiographic finding and a clinical finding, and when those two things correlate, that patient is typically going to do well from a decompression.
This was another really good question. I'd actually never heard this question before, so I'm curious to know if you even know the answer.
Okay.
Because it really has more to do with radiology.
Sure.
Is it common for, or I guess uncommon for the radiologist to literally write the measurement of the cerebellar tonsils on the MRI? So this particular patient didn't, they hadn't been writing whether or not there was any anomaly with their cerebellar tonsils on the report. Is that something that is frequent, or is it just kind of anomalous that would occur?
So we're a tertiary provider, as far as the field of neurosurgery. And so by the time somebody comes to see us, they will have had an MRI, and they're coming to see us for a specific problem, and our referral would typically say Chiari 1 malformation. So with that diagnosis, somebody would have measured it. And so to answer your question, most of the times when I look at an MRI finding or a reading on an MRI, it typically says Chiari 1 malformation with tonsillar descent at X number of millimeters, and then any other findings that might be correlated to that.
Okay. So it typically does.
It typically, yes. Yeah. All right. So to be very brief, yes.
That's fine. Oh, I did want to ask this. This was a really interesting question that came in earlier. If there is a clear reduction in the flow of cerebrospinal fluid at the back of the skull, so say someone had a cine flow study and they could tell that their physician could tell that there was a blockage of some kind, does that mean that patient needs a decompression, or is there something else that can be done either surgically or non-surgically to restore the flow at the back there?
Yeah. Again, so the one thing to consider is that when you are looking at these dynamic flow studies based on MRI, you are seeing an indirect representation of the CSF flowing. Now, it is typical that the reading will say something like restriction of flow, for example. And again, the way that some of the decompressions are done, they're relatively minimal decompressions, meaning the dura is only open for a small window, and the tonsils may be shrunk to demonstrate flow intraoperatively, to decompress the actual area. But a postoperative MRI in a patient like that may continue to show restriction of flow. So the way that I think of the imaging findings is, again, to correlate these findings to the clinical presentation. And so even if I have a postoperative MRI on a patient and the radiologist may read that there continues to be restriction of flow, but the patient comes in and they tell me they're doing great and they're back to being active and playing sports and doing the things that they want to do without symptoms, I don't worry so much about what the radiologist is saying on the imaging, but more about what I've done in the operating room and how the patient is currently doing at that point. So again, to be briefer in answering your question, what I would say is simply because the MRI is read as a restriction of flow, it does not mean that you absolutely need an operation.
Okay. I guess to piggyback off that a little bit, because I'm sure it's going to come up later.
Yeah.
So say someone did have a surgery, they come back, there's an obvious there's good flow, and it looks like there's nothing more to do, but the patient is still extremely symptomatic. I know that's probably the worst case scenario because, I mean, what do you do at that point? But what would be your general algorithm?
Yeah, so the first thing is that you want to give that some time. A patient coming back within a few weeks or even a few months of surgery and complaining of the same symptoms doesn't necessarily mean that is going to continue to have those symptoms down the road. So the first thing that I would do is make sure that we're not missing a postoperative complication, that the wound is well healed, that we don't have a pseudomeningocele, if let's say that we did open the dura, and that the postoperative MRI looks stable or even better than it did, before the decompression. As long as those things check out, I generally tend to wait and just have a conversation with the patient about being patient with the recovery and seeing where they are 3-6 months down the road, and then potentially readdress it at that point. I don't think you want to be quick to jump on going back to surgery because that may not be the way that patient is going to improve over time.
It could be more trouble than it's worth, I would think.
Well, anytime you go back to the operating room, you're going to put the patient at risk for certain complications. The other thing is that the more procedures that you do in that same location, there's scarring that you have to remove, and you may end up widening your exposure and potentially putting the patient at risk for iatrogenic instability, instability that is caused by a wide decompression as opposed to having some sort of underlying congenital problem that can cause it.
That's a really good point. So since you mentioned it, I'm going to ask the obligatory questions that we ask all of them. So when you operate, do you always open the dura and resect the tonsils? I know those are two different questions. And if so, if you do those things, how do you determine whether or not that's something that needs to be done?
So I'm a big fan of protocols, and I try to do every procedure using the same protocols, because I think that's one way that you can eventually go back and look at your techniques and look at how you're treating patients and learn from that and improve things or know what you're doing well that's working. So the way that I typically do the posterior fossa decompression is that I try to make a small incision. I remove roughly 3 centimeters of the occiput, but no more. I remove the posterior ring of C1, and then I thin out the dura. Before opening the dura, before making that decision, I use ultrasound guidance to look for pistoning of the tonsils, as well as the amount of CSF that is visible both behind and in front of the tonsils. If the tonsils are not pistoning, I generally tend to not open the dura. And the other thing that we do during these procedures is we do motor and sensory evoked potentials. And it's just interesting to see, and there's not really a lot of literature out there on this, but I can tell you my observation is that with the decompression, usually the bony decompression and the thinning of the dura, we tend to see improvement in the motor and sensory evoked potentials. Sometimes it's a huge improvement, more than 100%, let's say. And when I see that, and I see the fact that with the ultrasound, the pistoning is not visible. You basically see the tonsils just kind of moving with the cardiac cycle. And I see a good amount of CSF, a few millimeters of CSF that can be measured on ultrasound. I generally tend to stop and not open the tonsils. Following that, we generally have about 80 to 85% success in not needing to go back to surgery a second time. With that not happening, so we do the same procedure, but we continue to see restriction of CSF around the tonsils, or we see pistoning of the tonsils into the neck, then we generally do open the dura. And when I open the dura, I do shrink the tonsils and I do put in a patch every time. I've not left the arachnoid intact or done any of that. I generally get relatively aggressive with making as much room as I can so that hopefully the patient will recover well and not need to return to the operating room after they heal from that procedure.
Yeah. And I'm going to take this one out of time, out of like sequential again, but just for time's sake. Should someone be on specific medications for Chiari? I have a feeling it's going to have more to do with their symptoms, but are there medications that someone could take rather than going through a surgery, or if they've already had surgery, what are their options?
Yeah, you're correct. I mean, it really depends on what symptoms they're having. If they're having symptoms that were significant before the decompression and related to the Chiari 1 malformation, then after appropriate healing from the surgery and perhaps repeat imaging and other kinds of testing that could include physical therapy or um, then I think that you need to reconsider whether it's a good idea to do a second decompression. And perhaps if the first time the dura was not open, maybe the second time that would be a good idea. I'm not aware of any specific medication that can affect the Chiari malformation directly.
Okay. And then I guess if someone hasn't had surgery, this is really a question that I'm curious about because people call up not wanting surgery. Are there particular medications that you find are very helpful for Chiari symptoms, typical Chiari symptoms that maybe they can put off surgical intervention?
Well, with the typical symptom being generally an occipital headache that occurs with significant activity, and then the stoppage of that activity then causes the symptoms to basically go away. It's probably not a good idea to be taking medications like acetaminophen for the headaches that come on during that time. What I've actually seen, and this is just an observation, is that especially in the pediatric population, because those are really the patients that we see here, the kids tend to have a very high pain tolerance, and more so than their peers. And at least the ones that we think are symptomatic that deserve a decompression. And it's interesting to note that because usually when they come back to see us after the surgery, we hear from the parents that they're acting way differently and they're doing things that maybe they wouldn't have tried before, but not because they were complaining of pain, but maybe because they just weren't doing it and their pain tolerance was very high, and they just weren't comfortable with whatever that activity was. That's been something that's come up, more than infrequently when I ask families and patients that are old enough to answer my questions to tell me how they're doing after the surgery.
Yeah. And then I guess to go back to the question I had asked earlier, is it possible that symptoms are progressing? If the symptoms seem to be progressing, is that a sign that that sort of pain tolerance is wearing down? I guess this is a really complicated pain question, but is that something that might be the case?
I think the answer to that question is it depends, right? If the symptoms that are progressing are, say, cranial nerve symptoms, then it might be reasonable to assume that there is continued compression at the craniocervical junction. It's putting pressure on the cranial nerves, and that is causing worsening, say, swallowing difficulty, for example. If the symptoms that are progressing are more related to pain, then you'd have to evaluate exactly if the pain is related to the Chiari 1 malformation, or is it related to the fact that you've had a decompression and now there's a scar there, and there could be pain related to postoperative scarring. So I think it all depends on what the specific situation looks like.
I didn't pose this question this way earlier, but I do want to ask it. So is there a risk if there is no surgery? For instance, you talk about the pistoning where the tonsils come down. Is there a risk of long-term injury if there is no treatment for this?
I guess I would have to tell you that there is a risk. I can't tell you what that risk is. I think that risk is very low. We've seen patients that run the gamut of the presentation, and even patients that were diagnosed after a severe motor vehicle accident, let's say. Now, you could maybe make the argument that perhaps the significant impact may have, the trauma may have caused the Chiari, I suppose. But if you assume that this is primarily a congenital problem and it was probably there, and they survived a motor vehicle accident that was a significant impact, and they're not having symptoms related to the Chiari, that that it's unlikely. So I think it all depends. Yeah.
A really interesting question just came up. So, and I think this is more philosophical. So, is it pain tolerance, or is it just not knowing what quote unquote normal is? And I think to pose it as a question that's answerable, have you noticed that after surgery, some of your patients will, and again, this is anecdotal, but they feel less pain, like they're surprised that they don't have a headache anymore or something like that, or other symptoms, I guess, too.
Yeah, so what I was referring to earlier is really what we've again anecdotally identified in the younger patient population. And so those are not generally the kids that will complain of pain, but what we hear from their parents is that their energy level is way higher than it used to be. They're running around all day now, when before they really weren't doing that. They're playing new sports that they really weren't interested in trying before. So to me, it almost seems like, to get philosophical about it, it almost seems like the child was experiencing something that they couldn't describe, but something internally would tell them not to perform a certain action, not to participate in a certain activity that now was, say, freed, and that feeling then goes away, and the child becomes more active. But there's no way to ever really prove that. We like to be very objective when we talk about science and the hypotheses that we try to study. And so this is, like you said, very philosophical and very subjective. And I am sure that there are people out there that probably would disagree with this, but it's just an observation that we've made in our clinics.
Of course. This is an interesting kind of follow-up question, even long-term. I don't know the answer. How often should a decompression surgery be checked, as far as like the success of creating space there? How often should it be checked via MRI to ensure that the surgery, that you don't need to go back in if there's maybe scarring or something like that?
Yeah. So my general rule is that if we're recommending surgery and doing a Chiari decompression, say for someone who does not have a Syrinx, I would see how the patient is doing postoperatively and get one MRI around 6 months to a year after the surgery. If the patient comes back to our clinic and tells us that they're doing fantastic and there's really no concern, there's really no reason to be rushing back to get a scan. And we try to limit the number of scans that we get. So you may get a scan about 6 months to a year later. We tend to follow our patients every 1 to 2 years, depending on their age. And if they continue to do well, that may be the only time you get the image. It's a little bit different if you're following somebody who presents to you with a Chiari and a Syrinx, because you'd like to know that once your decompression is completed, that you don't have any complications from that, and that the Syrinx is hopefully decreasing in size, or at least stable and not looking worse. And so those patients you would probably scan a little bit more frequently, because we know that you're going to probably see a change at 3 months, but it could be 2 years until the Syrinx is either as small as it's going to get, or finally stabilized.
Yeah. So how far out, I guess, have you followed a patient? I guess specifically with a syringomyelia and then without, because they're two different animals.
If they're very young, if somebody presents to us, let's say they're 2 to 3 years of age, we may follow them until they're a teenager. But we're not going to see them every single year, and we're not going to get imaging very frequently unless we get the clinical story that something is changing and it would make us concerned. We would do something similar whether the patient had a Syrinx or not, but there will be other symptoms that we would be concerned about with a patient that has syringomyelia. And while for someone without syringomyelia, you may get a follow-up scan that is a craniocervical junction MRI. With the Syrinx, obviously, you need to get more imaging than that if you're going to follow the Syrinx itself.
Okay. Let's see if I missed any. I don't think I did. Okay. Oh, actually, yes. There's a question in the chat. Can aseptic meningitis after surgery, this is again very specific, be a response to an allograft, which is, I'm going to let you define it actually. If so, how would you manage that? And would you expect something like that to get better over time, or would you need to address it long term?
Yeah, it should resolve over time. So basically, an allograft is going to be a dural patch that you're going to place to make more space while you're doing the decompression, and an allograft is not native to the patient. So it's going to be some sort of, if I can call it, foreign body that you're going to implant to then allow enough, allow healing that will then create a larger space back there. So when you have an aseptic meningitis, we generally treat it with steroids. It's not the type of diagnosis that necessarily requires a reoperation. Usually, when somebody presents to us and we have those kinds of concerns, we'll get a follow-up scan to make sure we're not missing a real infection, a bacterial infection, let's say, or some other problem. But if we deem that this is an aseptic inflammation related to a graft or to the surgery, then the patient is generally admitted for a few days, put on high-dose steroids. They tend to get better with some strong corticosteroids, which we usually would give in the hospital as opposed to sending the patient home. And that's really been my experience with treating aseptic meningitis, and it very successful.
I don't know that we really got into this, but this is a good question, and I don't know how to even answer it. The symptoms of craniocervical instability and Chiari, how do you differentiate them, I guess is the first question. And then how do you know what's the real problem and what to operate on? That makes sense.
Yeah, so in our population, we generally don't see frank craniocervical instability with the presentation of the Chiari. My general approach is not to do a decompression and a fusion at the time of surgery. So what we would generally do is decompress the Chiari, probably in those cases, open the dura, shrink the tonsils, and place a patch, and then closely follow the patient postoperatively to see how they're doing once they've healed from the surgery. If they, let's say they have a retroflexed odontoid, if they have some signs and symptoms of instability, then follow-up imaging with MRI and probably some dynamic x-rays as well, and measurement of some of the lines that I mentioned to you earlier would kind of point us in a direction as to whether we could continue to be conservative or we'd have to talk about a posterior fusion, which is what probably would be the next step if they needed some type of fusion. Ah, there it is. Yes, perfect.
Yeah.
But that's generally how we would think about this problem. The Chiari is usually the symptomatology that the patients present with. Now, if there's an associated Climal file, some other skull-based anomaly that we have to address, like I said before, usually we don't have to do both of those procedures at the same time, and you can wait and decide whether the fusion is really indicated.
Yeah. We've gotten this question a little bit. Where, in the setting of a Chiari patient, where do you typically see the Syrinx form? And have you seen atypical Syrinx locations?
Yes. So typically the Syrinx is in the cervical spine. And a lot of times when you do the craniocervical junction MR, you will pick up maybe the top of the Syrinx or some anomaly there. The other thing that we tend to see sometimes, and I don't know if this has been described in the literature too well, but from a radiographic standpoint, sometimes we actually see a signal in the center of the cord that is not an injury, but actually our radiologists call a pre-Syrinx. So it looks like essentially a T2 signal that shows some inflammation where there could be some restriction of flow and potentially the beginning of a Syrinx. And so those patients we tend to rescan within a few months to see if there's any change going on that correlates with that. We have seen Syrinxes in the thoracic spine as well, however, frankly, the literature would tell you that those patients that have a Chiari decompression with a thoracic Syrinx, that Syrinx is less likely to improve when you compare it to Syrinxes or syringes that are in the cervical spine or higher up, closer to the Chiari malformation.
Will it ever get as low as lumbar, or is that more indicative of something else?
Yeah, I mean, typically the spinal cord ends around L1 or L2, so you wouldn't see it any lower than that. And I have seen holocord Syrinxes that actually can start all the way from the the bottom or even within the brainstem as a syringobulbia and extend all the way down to the conus. And so the answer is yes. It's unusual to see an isolated, high lumbar Syrinx. That's usually, I would say that's typically more related to a tethered cord than something related to the Chiari.
What are the alternatives to surgery for Chiari patients and maybe for syringomyelia patients as well?
There are very few, let's say that.
Nice.
And I'm not sure how well the success rates would be related to the fact that if you really need an operation, that's going to be what's going to make the patient better. Certainly, we believe that if you have a Syrinx, you have abnormal CSF flow dynamics that are causing that Syrinx. And so if there is an associated Chiari-1 malformation, the general belief is that those two are related to each other. There have been some studies that have discussed manipulation of the spine, of the craniocervical junction, as well as the craniosacral axis. But I am not sure that you're going to be able to objectively study the results of something like that. And so I do think that physical therapy may have a role. I do think that some kinds of myofascial techniques that can help with back pain and neck pain may have a role. But as far as improving CSF dynamics, I'm not sure that external type of manipulation, let's say, or high velocity, low impact type of techniques are going to really get to the heart of the matter, which is the abnormal CSF dynamics within the spinal canal.
Yeah, that was actually one of the questions that had come in beforehand about chiropractic adjustments, possibly restoring normal flow. But
yeah.
I guess
the thing I'll say about that is they may work for some people, and there's really very low risk involved with it. So it's unlikely that your symptoms are going to get worse from some sort of manipulation, as long as it's not a high cervical manipulation, at the level of the Chiari itself. But if we are talking about, like I said before, about some myofascial techniques or some sort of biomechanics to improve, say, spinal alignment, or at least preventing muscle spasms and those kinds of things, I think that patients will feel better from that. Especially those that present with scoliosis, for example. They're going to be at risk for increased tightening of the thoracolumbar musculature specifically, and even in the neck. So I think there's a role for it. I just don't know that there's a way to really study it where we can objectively measure something and say you're better because of the manipulation.
Right.
Like I said at the beginning, there's low risk involved, so I wouldn't say that it's contraindicated as long as you're not talking about manipulation at the craniocervical junction.
Yeah. Well, this has come up in other Q&As. What are your thoughts on, I think I know the answer based on your answer previously, but things like acupuncture and different things like yoga or stuff like that?
Yeah. Again, very little literature out there on those kinds of alternative medicine paths. Um, and you're right. I mean, my feeling about it is that the risk is low, and if it works, there's nothing wrong with trying that. I certainly wouldn't steer anybody away from trying whatever may work at a more conservative level before agreeing to sign consent for an operation that's going to have way more risk than some of the things that you mentioned.
Right. There are a lot of really good questions coming in. Okay. So, oh, I lost it. So disc lesions and degeneration. Is this something that's not necessarily caused by Chiari, but is it common in patients with Chiari or cervical instability? What would you say to that? Is there any recommended medications for those things, or is that surgery as well?
So the patients that, you remember, I'm at a children's hospital, so
Right.
the patients that we see that have desiccated discs or early degeneration of their, especially the cervical spine, they're usually patients that present to us with congenital anomalies. The typical adult patient is gonna have degenerative disc disease because they've lived and they're older, not necessarily because they have a congenital problem that's going to predispose them to that. And so the kids that we tend to see with those kinds of issues tend to have significant problems in their bony cervical spine. So kids with Larsen syndrome, let's say, Klippel anomalies, and they're going to be more difficult to treat than the typical simple Chiari-1 malformation.
Yeah. This is interestingly posed. So are there any procedures or invasive tests that can cause or worsen Chiari malformation, the herniation of the tonsils, or symptoms? And are there any procedures that can reverse that? So maybe instead of sucking it down or pushing it down, maybe sucking it back up. What would you say?
Well, I mean, I probably something like a high volume lumbar tap, or commonly known as a spinal tap, may not be a great idea in somebody that already has a Chiari malformation. So not necessarily that it's contraindicated, but if somebody absolutely needed CSF to be tested for some reason, and they also had a known diagnosis of a Chiari-1, I think you could still relatively safely do that procedure by only removing a few cc's of CSF. But a high volume tap, say that if you wanted to check for a result of somebody perhaps having idiopathic intracranial hypertension, and you wanted to remove a lot of CSF and see if their headaches got better, probably not a good idea to do something like that for someone with a known Chiari-1. I'm not sure that I can think of a way that you could float the tonsils. Generally speaking, we believe that part of the problem with the Chiari-1 malformation, I should say, is that the volume of the posterior cranial vault is actually very smaller than it should be, or the tonsils are larger than they should be. And so there's really if you believe that there's really no great way to make space other than maybe removing some of the bone or thinning out the dura, which is what we do when we're doing a decompression.
Yeah. This brings me to my favorite causality question, but it touches on it actually. So are there, I've lost the question. Chiari in children anyway, that I know of, can maybe go back up just based on growth or just the way they were sitting that day when they got the MRI. Is that something commonly seen in kids and adults? And what would you say about that? Is maybe that's why people think that certain procedures may or may not make it go away, or
Yeah, so it's not common. What I generally tell our patients is that you can think of the diagnosis of a Chiari malformation as patients fitting under a bell curve. The great majority of the kids that we see, they're going to look exactly the same, especially if they're asymptomatic, when we scan them year 1, year 5, or year 10. Infrequently do we actually repeat imaging that shows that the tonsils are further down into the neck, or there's a greater restriction of flow, let's say. And infrequently, and I would say I probably have this discussion less than 5 times a year, where somebody comes in for a follow-up and the Chiari is measured at being less of a tonsillar descent than it was the year before or the years prior. So it does happen, but very infrequently, and we really don't know why.
Yeah.
My general belief is that I tend to see it more in the younger patients, and my feeling is that as they grow and their skull grows, perhaps more room is created by growth, and so there's more CSF that fills that space, and then it looks like the tonsils are actually less descended into the neck, when in reality that there's actually just more space, and when you measure it, it just doesn't measure as low as it was.
Yeah. And if that anomaly were to happen in an adult, I mean, this is obviously conjecture, but what would you say is the possible reason for something like that?
So that
Yes.
we would have an adult with a Chiari 1 malformation that had follow-up imaging that showed improvement.
Yeah.
That showed improvement in the Chiari. Boy, I really can't think of a specific anatomic reason for that to change, only because, again, by the time you get to adulthood, you think that everything is static, meaning the size of your skull is static, the size of your brain is static, and obviously the CSF around those structures is going to be static. So yeah, I'd love to hear from some of my adult neurosurgical colleagues if they have some hypotheses on that.
I think some of them do. I want to get to this. This is very pediatric focused, but what are the specific symptoms that parents should be looking for in infants, toddlers, or their elementary to high school kids, which is like all of them, for if you were going to operate on a Chiari? And would scoliosis factor into that? And
Right.
That's a very large question, so I'll just let you know.
So okay, let's just divide it up into the two age groups, or let's just pick two age groups, and we'll just say infants and toddlers, and then anybody who's older than that. And the reason I break that up is just because when they're older, they can talk to me and tell me how they're feeling, and when they're very young, you're doing a neurologic exam, and many times trying to ascertain what you're seeing and trying to correlate that with signs and symptoms, perhaps, of the Chiari 1. So if we have an infant presenting to us, usually when they come to us, they tend to be the patients that have the more severe Chiari malformations. So they're the ones that tend to present with the cranial nerve abnormalities, the difficulty with swallowing, the failure to thrive, because again, they're not getting enough nutrition. They may have macrocephaly, they may have enlarged ventricles that are not necessarily explained by just the diagnosis of hydrocephalus itself. So those are the kinds of things that we look for. Obviously, an infant is not going to be running around and getting the exertional headaches that we typically ask about in an older patient. With a malformation that might look more severe on imaging, so more restriction, less CSF flow, you may look for some abnormal reflexes. If the patient is a toddler and they've been walking around and running around for a year or two, you look at their gait and you look at how they are, say, going up and down stairs, if they're advanced enough to do that. Sometimes, we'll have families tell us that it looks like maybe the child is dragging his or her leg, or not necessarily symmetric in the way that their ambulation looks. And so those are the kinds of things you want to observe. But certainly it's more difficult to make a determination on a pediatric patient who's very young, who can't answer questions. Now, the teenagers or even the younger kids that are school age, the easiest way to diagnose those patients as being symptomatic is because generally they want to run around, they want to play with their friends, they want to be, fighting with their siblings, let's say. But and if they're not doing that, and that's unusual for them, and they happen to have pain in the back of their head with exertion, well, there you go. I mean, that's an easier way to make that determination. Those patients are less likely to present with significant long track findings unless they also have a really significant Chiari, which we see that not frequently, but also not too infrequently, where there's a cervical thoracic Syrinx or even a whole cord Syrinx in an older patient who's pretty much been dealing with that. And for whatever reason, someone ends up scanning them, and there you go. Now you've made a diagnosis of a really big problem.
Yeah. Does scoliosis factor into your decision making as far as surgery is concerned, and what's the process for that?
we definitely take that into consideration, and there have been papers written on the incidence of scoliosis and the Chiari-1 malformation. To me, I think it's more significant if we have a Syrinx associated with the Chiari-1 and the scoliosis. I would certainly want to involve an orthopedic surgeon in the decision making and discussing with him or her is the curvature progressing? Is it something that is restricting the patient? Does it look like he or she is going to require a fusion or a correction of the scoliosis because of it? And so in the scenario that I've given you, I would more than likely be recommending a decompression than not, because I would like to see if we can slow down the curve progression and perhaps even avoid a correction of the scoliosis, especially with the Syrinx.
Yeah. To that point, at what point do you operate specifically for syringomyelia? So how long do you watch and see, as they say?
Yeah, so typically speaking, if the patient has, so if we're talking about someone with a Chiari-1 and symptoms related to that Chiari-1 with a Syrinx, we generally would recommend a decompression when we meet the patient because we've got a normal CSF dynamics and we have symptoms. With a Chiari-1 malformation and a Syrinx, what I would say is, in my mind, it sort of depends on where that Syrinx is, if they're not symptomatic, the size of it, and really having a discussion with the family and getting a sense on how they feel about the diagnosis. If we're talking about a 2 millimeter Syrinx that you see in the mid-thoracic spine, and the patient has, say, a 5 or 7 millimeter Chiari, that's probably something that you could watch if they're not symptomatic. If someone has, a 2 or 3 or 5 millimeter Syrinx in the cervical spine, to me that's a little bit more of a concern. And so I'd want to know from the family how strongly they feel about observation or not, because frankly, nothing is going to change overnight when you diagnose a Syrinx. If somebody presents to you with a Syrinx and no symptoms, they're generally going to remain that way, maybe indefinitely, but certainly if you waited 3 months and repeated the imaging, more than likely they're not going to become symptomatic in that period of time. And usually, if they develop any symptoms, they're going to be slow and insidious symptoms. They're not going to wake up one morning and have, say, difficulty, making a fist or something like that, So I think that it would be unusual for me to recommend an emergent decompression for something like that.
So I have a couple of heavy hitter questions that I guess I'm gonna have to burden you with. This one's kind of specific. If a second decompression is required after an original decompression with a fusion at the craniocervical area,
okay,
is the second decompression possible when if there's a solid fusion in place, or would the fusion need to be kind of taken apart in order to do that second decompression?
Mm-hmm. So if we're talking about a C1-2 fusion, then you're more than likely you could just leave that alone because your decompression is more than likely above that fusion level. I'm assuming your question is related to an occipital cervical fusion. Now, if you're talking about an occipital cervical fusion, it depends where the occipital plate or the occipital screws were placed, because if they were placed over the midline, then you may have to take down some of that and just redo the fusion after the decompression. If the plate or the screws were placed lateral or above your bony decompression, then hopefully you would have a window to re-enter the same area without really worrying about the fusion mass.
Okay, that was a good answer. This is the question that a lot of people ask, and I think it's definitely best answered by a physician. Can Chiari be life-threatening? Chiari specifically, I would specify.
The Chiari-1 malformation.
Mm-hmm.
So
yeah.
you never want to say always, and you never want to say never. when you answer any question, because I don't think that that really exists, right? There's always going to be the anomaly. But if I can answer for the general pediatric population that I take care of, I have not seen a Chiari be life-threatening unless the patient presented to us with acute symptoms that usually are correlated with brainstem compression or brainstem signs that typically go along with a significant syrinx. So what I would say about the question you're asking me is, if you're just talking about a Chiari 1 malformation, I would say the answer is most likely not. But patients that present with significant symptoms that require urgent treatment usually have the Chiari 1 with some other problem. So Chiari 1 with, say, significant instability related to maybe something else that's congenital, or Chiari 1 with a significant syrinx that is just creating so much compression at the craniocervical junction that is causing life-threatening symptoms. Because really the life-threatening symptoms occur from compression of the brainstem. And so there has to be something that is causing compression of the brainstem to cause a life-threatening situation.
Right. That was good. That was very diplomatic. This is interesting. Is there a way to differentiate pain or burning, tingling, like syringomyelia kind of symptoms from symptoms of compression or instability that could cause similar things? Is there a way to differentiate what those might be without addressing one or the other, I guess?
Yeah, well, I mean, typically with instability, you should have. I mean, as far as the typical presentation, either or a combination of sensory and motor symptoms, because the instability is not only going to affect the dorsal portion of the cord, but also going to affect the anterior portion of the cord, which is where the motor tracts are. Generally speaking, it's unusual for a patient with a syrinx to present with weakness. I suppose they could, but usually what they present with is this, the textbook answer is that there's this cape-like distribution of, dissociation of sensory symptoms that are, over the shoulders, onto the arms. But that doesn't necessarily have to be the case, right? So typically what we're looking for is some sensory changes that could correlate with the level of the syrinx. That's the other piece of this, is that, if you have a thoracic syrinx, especially like say mid-thoracic syrinx, it's unlikely that you're going to have symptoms in your hands or your shoulders. If you have a high cervical syrinx, you could have symptoms from that level down. So you'd have to also correlate the neurologic exam to where you think either the instability is or the syrinx is located.
So what would be some of the related conditions that might cause weakness and itching in the face and the neck? Would that be assuming I'll be clear, it's probably a hollow cord syrinx that we're talking about, but could that cause facial and neck problems, or would it be strictly your extremities?
Yeah. The sensation to the face really comes from the cranial nerves. So I suppose that if you had a higher problem, meaning that it was affecting the brainstem, you could get sensory changes in the face. But typically, if you're talking about a cervical syrinx, those symptoms that are sensory related are going to be more around the shoulders and the arms, like we were just saying before.
Okay. I wanted to ask two questions sort of out of left field for the discussions we've been having. And I'll also say last call for questions in the chat. But I wanted to kind of touch on seizures and dystonia and what are those things, and can you tell the difference between those and symptoms, other symptoms in children that might mimic I don't know, like epilepsy or something? How do you differentiate things that could happen in a Chiari patient versus everything else, I guess, in pediatrics that would address that?
Oh, so anatomically, we're talking about two different places. So we don't necessarily believe that the cerebellum or the tonsils of the cerebellum are responsible for causing seizures. Seizures occur in the supratentorial compartment of the brain. And so the easiest way to diagnose seizures is with an EEG. Obviously, an MRI can give you some clues to it if you actually see abnormalities that are related to the semiology of the seizure. So once again, we go back to looking at the clinical exam as well as the radiographic finding. And then if we're talking about a neurologic condition like seizures, the EEG findings that would go along with that. If you put those three pieces of information together, it shouldn't be difficult to ascertain where the seizures are coming from, or whether they're actually real seizures or pseudo seizures that maybe don't have any sort of abnormality through the cerebral cortex. And dystonia is the same way. I suppose that if you had long tract signs within the spinal cord, you could get symptoms that may look like dystonia. But if you also had significant intracranial abnormality, brain abnormalities, that would be the other place that those symptoms could come from. So again, you would correlate the findings on the imaging to the findings on the neurologic exam, and that would significantly help you to figure out what exactly the problem is, so that you're not treating the wrong thing.
Right, and that's something I guess it goes without saying that a neurosurgeon or a neurologist should be looking for in that exam.
Yeah, typically the neurologist would be the subspecialist that would be looking at patients that have seizures. They typically would refer a patient to us, on the surgical side of the neurologic diagnosis, once the diagnosis of seizures is made, or once the diagnosis of dystonia is made, to discuss whether deep brain stimulation or some sort of invasive monitoring might be necessary to further diagnose the seizures, let's say.
Okay. Yeah. And then I just wanted to touch on this really quick, because I know you studied it a lot, and I assume you see it a lot because it's pretty common in pediatric neurosurgery. But can you just kind of go over what hydrocephalus is, how it might be related to CSF flow, maybe Syrinx, and how severe is it? So when a child comes in with hydrocephalus, like, how do you know what the next steps are and how urgent it would be?
So are we talking about hydrocephalus in general, or are we talking about hydrocephalus with Chiari-1 malformation diagnosis?
Since it's different, how about both?
Yeah. So those are two completely different things, right? So there are many different etiologies of hydrocephalus, and we see it from birth or even prenatally on fetal MRIs, all the way to the oldest children that we might evaluate in our clinic. So when we diagnose a patient with hydrocephalus, it means that they have ventriculomegaly with increased intracranial pressure that is causing some symptoms. In the neonate, the fontanelle, the anterior fontanelle is open, and so many times they will present with macrocrania or an enlarging head circumference that crosses percentiles very quickly. And they could have significant symptoms related to brainstem compression or just overall increased intracranial pressure, to the point that it could be a fatal condition if it's not treated. For a patient that might present with a Chiari-1 malformation and hydrocephalus, that's a much smaller percentage of individuals that fit that diagnosis. Sometimes a patient will present with some level of ventriculomegaly and the Chiari-1. And generally speaking, if their symptoms are primarily related to the Chiari-1 malformation, we would recommend doing the Chiari-1 decompression and then just observing the ventricles and seeing what happens. We know that those individuals that have enlarged ventricles and a Syrinx and a Chiari-1 malformation actually tend to do quite well with a decompression. The flip side of that coin actually is that sometimes we decompress a Chiari in a patient that has normal ventricles, and postoperatively they develop ventriculomegaly for some reason. That percentage is very low. It's less than 5% of, or around 5% of patients that have a Chiari-1 malformation that's decompressed. Many times that can be a temporary condition that does not require ventriculoperitoneal shunt placement for CSF diversion that is permanent. And the few patients that I have treated with that condition, we either treated with steroids or treated with steroids and an external ventricular drain. We decompressed their ventricles, improved their symptoms, and then slowly weaned the EVD. And for those patients, we were actually able to remove the EVD and not need to shunt them. But there are patients out there that have developed hydrocephalus that have required a shunt, that actually have a ventriculoperitoneal shunt after a diagnosis of Chiari 1. But those are, especially for us in the pediatric population, that is a very low number of patients, a low percentage of patients.
I do want to ask this question because it just came up. If someone hasn't had surgery or any other treatments for a Chiari, and actually I believe this is an adult, so should they be on any particular medication? Should they be doing anything specific to either maybe stave off surgery or get to the point where surgery might become necessary? Is there something they should be doing in the interim?
So yeah, you know, treating in thinking about the philosophy of treating the whole patient, not just treating what you're seeing on an MRI in the posterior fossa or whatnot. There are some really basic things that you can do. There's no, you know, I wish that there was a medicine that I could say, hey, take this and you're going to be fine. There isn't. But you know, the things that you can think about and that I think will be beneficial will be really simple, and you know, maybe simple to say, maybe not simple to put in practice, but essentially the answer to the question is to, you know, to live healthily. What that means is that, you know, have a good diet. What that means is, you know, exercise, and you know, get a normal amount of sleep. You know, the kinds of things that help people, you know, live a healthy life, you know, beyond what medicine might do for you. Those would be the things that I would recommend. Especially, you know, if it is an adult asking this question and there are comorbidities associated, you know, definitely try to treat those comorbidities. If you're not exercising, if you're drinking alcohol, if you're, you know, doing things that you shouldn't be doing, the first thing I would do is cut those things out of my diet, and like I said before, get on an exercise program and just try to improve your, you know, cardiopulmonary system and the rest of the you know, the physiologic systems within the body that may not necessarily appear to be related to the Chiari 1 malformation, but all in all might actually help significantly down the road.
Yeah, I have two follow-ups to that. One I just thought of. So as far as exercising, because I know the Valsalva maneuver can cause a headache. So I don't know if that's something you can talk about, or if I should get a PAT to come on, or
yeah, you know, obviously you're not going to want to go out and, you know, run a marathon or, you know, start benching hundreds of pounds of weight, but you know, there certainly is mild exercise that everybody can participate in that would certainly help them and not necessarily you know, accentuate the Chiari symptoms too much. So you know, something as simple as walking. So many of us these days are sitting in front of a computer working because of, you know, the pandemic and the situation that we've been placed here in the last number of months. But you know, getting up and walking a number of miles at least every few days, that could go a long way, and doesn't necessarily increase your heart rate or blood pressure or intracranial pressure all that much, but it's still very good exercise. So it all depends on what your starting point is. But you know, stretching, yoga, like you mentioned earlier, those can be really good exercises where you maybe it doesn't appear like you're doing much, but your body will certainly thank you for it.
Yeah, and I definitely recommend air squats. Those are the best. And then two other questions. So one has to do with this. As far as limits on activities, I know that's like a hot topic that people talk about a lot. Are there any limitations that you put on your patients, either who have or have not had surgery, and why?
Yeah, I try to be not too restrictive of activity. So I know that, you know, depending who you talk to, you're going to get a whole gamut of do nothing, or you know, you can do anything you want. My philosophy about this is I wouldn't want a parent or a child to be put in a situation where, you know, there's a higher likelihood of being injured, understanding that anything that you do could lead to an injury. You know, you could trip going up the stairs and injure yourself. So for boys, I generally don't like them playing tackle football or organized, you know, American football, because it is a relatively more aggressive and more violent game than other games that you can participate in. But I don't necessarily keep them out of games like baseball or basketball or even soccer, depending on their age, because you know soccer itself can become a quite an aggressive sport as well for you know the older teenagers. Similarly for girls, I'm not a huge fan of you know competitive gymnastics where you might be trying to do a flip and land on a very thin bar. I think that that's putting yourself at risk, but at the same time, there are plenty of other sports that you can play that are going to be very unlikely to you know lead to an injury. And so those are the kinds of recommendations that I make. I don't think any of us are big fans of trampolines, and certainly when you have multiple people on the trampoline, that's when we find out that people get hurt. So you know if you absolutely needed to jump on the trampoline, I would say you know do it by yourself and you know don't flip. And if you start having some symptoms by jumping, please stop. But again, I don't draw a very hard line around a lot of activities because I want the kids to be active. I want the kids to be out there and be with their peers and be with their siblings and enjoy you know their childhood.
Yeah. And when you talked about trampolines, I just had like flashbacks to being in bouncy houses and oh my God. um, and then I think the last question I just want to end with is really pertinent to just the moment that we're in right now. So there's a global pandemic. People are trying to people still have Chiari or syringomyelia and all that. How can people get in touch with you if maybe they want a second opinion? I know that's a really big thing that some of the laws have been relaxed temporarily for that kind of stuff. So how can someone get in touch with you, and are you willing to kind of offer that service, I guess, for now?
Yeah, well, I mean, so we like I think almost every other institution, or you know, certainly around the country and probably around the globe that has the ability to do it, has developed you know a telemedicine platform, and we do as well. So there are many consultations that we do for patients that are out of state, where as long as we can see their images, and the other thing that I like to have is the patient on the video call as opposed to only talking to the parent. And granted, you're never going to have as good of a neurologic exam on video compared to seeing the patient in the clinic and being able to check their reflexes with your own hands and check their strength with your own hands. But you get a pretty good sense, you know, on how they're doing. So we do that on a regular basis, and certainly, you know, we don't turn anybody down if they want to come see us for a specific neurologic and potentially neurosurgical diagnosis. So it's very simple to find us online and to get a referral. So.
All right. Well, I don't think there were any questions after all that. So I just want to thank Dr. Mangano for joining us tonight. This was really, really great. And thank you all for joining us as well. Mary just shared a thing in the chat, so please click that. And I guess that's it. So thank you so much, Dr. Mangano.
Oh, you're welcome. It's been a lot of fun, and thank you for inviting me to do this. And hope everybody has a good evening, and we're able to maybe do this in person sometime.
One day. Have a great night.
All right.
Thanks, everyone.
Bye.